Good afternoon to everybody. Another opportunity for you to ask questions. And as you say, we're not personal, but broad questions. Alan Thompson is my name. I'm a neurologist from London, and my two co-panelists who will be answering all the questions are Mar.
So my name is Tintore. I am a clinical neurologist working here in Barcelona, seeing patients for many years, and I had also the privilege to be local chair in this fantastic ECTRIMS 2025.
And Romain?
Thank you. Good afternoon. I'm Romain Marignier. I'm a neurologist as well. I'm working in Lyon, France, and I'm also working not only for MS patients, but related disorder to MS like NMOSD and MOGAD.
So we're looking forward to receiving your questions, but before we do, perhaps I'll ask Mar what her highlight of the last quite exhausting 3 days was.
Yeah. So it's been a fantastic experience. We have really heard all the novelties. If I have to summarize, we have been hearing more about the new diagnostic criteria and already seeing the impact in real life and confirming that with these new diagnostic criteria, we are able to diagnose more patients and to diagnose earlier. As you know, that we are moving from a more clinical diagnosis to a more biological diagnosis. That means that we have the tools to identify this disease even before the symptoms onset. And we know that this is clearly impacting then prognosis. So in terms of one of the first highlights, I think early diagnosis would be my first choice.
Great. And just before I turn to Romain, just to say, you need to write your questions in English because unfortunately, although my Spanish is all right, it's not that good. So English is the better option. So Romain, what about a highlight from you?
Yeah, so to echo Mar, what also was for me very interesting is we are also some new criteria for differential diagnosis because it's good to improve the diagnosis of MS, but it's also good to improve the diagnosis of mimicking of MS, so diseases that look like MS but are different, and this is very impactful because we know now that they are not responsive to the same treatment. So there was a nice session dedicated to one of the main differential diagnoses of MS, which is called neuromyelitis optica, which shares some clinical features with MS, but it's clearly different in terms of course and response to treatment. And to be honest, it's still a bit complicated. We had a lot of discussion, but one of the main discussion was also to improve the biomarker for the diagnosis. As you know, unfortunately for MS, we still have no definitive biomarker for the diagnosis of MS, but we have biomarkers for the diagnosis of differential diagnosis, and we are improving and standardize also the way of detecting this biomarker. So for me, it was also very interesting. And in more broad picture, we have a lot of discussion about homogenization, so speaking the same language among all the laboratories in Europe and the world for these biomarkers.
Great. So we're getting greater clarity and we're diagnosing earlier with greater certainty. That accuracy is really important. So I'm going to turn to some questions. And there are 2 or 3 have come in around diet in MS. And there's 2 specific questions. One is the role of dairy products, whether they're actually good for you or not. And the other is whether there's any role for the microbiome in MS. So difficult questions.
Difficult questions with not straight away answers, but yes, we are more and more understanding that lifestyle matters, and it matters a lot. No, we heard, for example, that ultra-processed aliments were clearly not recommended. We have information related to Mediterranean diet, and so diet is clearly having an impact. In terms of microbiome, this is also a field that is currently having a lot of attention. We know about this immunological connection between our gut and our brain, so there seems to be a clear connection between the two. Having said so, this is not straight away. We haven't found a clear microbiome that defines MS. I would say that even what is normal is not clear.
No.
Because we all have differences, and in an individual also difference across different moments of their lifetime. No? So there's still a lot to be learned, but clearly this is something that deserves further investigation, because probably the same way that lifestyle, all the things referring to our microbiome, will have an impact also in how our immune system responds to the disease.
Sure, absolutely. So I'm going to change topic completely and talk about the menopause. So we have a very interesting question from Laura, which is basically what impact, I'll come to you, Romain, as well on this, what impact the menopause might have. We know the impact of pregnancy on MS, but what about the menopause? And in particular then, what about progesterone levels? Any comments on that?
So we know that MS is a disease that is clearly more frequent in women, and therefore women go through a different lifespan, and menopause is clearly a state in which we have to learn how the disease is modified. I would say that MS is a disease that clearly changes with aging, and therefore we know that children do have a very inflammatory disease with a lot of relapses, a lot of activity, but on the contrary, a very good recovery and very little neurodegeneration.
Yeah.
With aging, we have the opposite. We have less acute inflammation, less relapses, but more neurodegeneration, more acute chronic inflammation. And this is what we see in relation to menopause, okay? What it is not clear is what is the effect of the decrease of hormone levels in this more global aging process. There are conflicting results. There is a very nice MS-based study from a huge number of women showing that there is definitely a clear, slowly increasing disability during the aging period, but they could not find like an inflection point just related to the moment of the menopause.
Yep.
So there's definitely an aging processes, probably hormonal, sexual hormones are part of this equation. How much of this equation is only driven by hormones? I think there's still some more studies to be done.
What about from your point of view, Romain? And before you answer, just to say, some people are having difficulty finding us or have missed the beginning, and all of this will be recorded, so it will all be available to you. So don't worry about that. Romain, anything you'd like to say about your...
That's a good point. We have a nice session, nice discussion about the aging. I think it's a new concept, very interesting. We were not so much focusing on that before, and we know now that, as you said, Mar, the dynamic of the disease itself is changing with age, with a new concept quite interesting about immunosenescence, which can be a good thing in a way because the disease is less active, but also maybe more associated to processes that are more difficult to handle, like neurodegeneration. And associated to aging, unfortunately, there is comorbidities. So comorbidities is associated diseases with MS. We know that there is a higher risk of other autoimmune condition, but mainly higher risk of disability associated to age. And the other things to be considered is how we should manage the treatment, because it's quite easy as a clinician to start a treatment. I know we have very active drug for MS patients and related disorders, but we also have to think about how to de-escalate because of age, which is the balance in between the benefit of the treatment and maybe the risk associated to the treatment. And we know now that the risk is increasing with age.
Sure.
And I think it was a very nice discussion. There was a workshop that was dedicated to de-escalation. That means to decrease the intensity of treatment and also stopping treatment. I think it's a very new concept in the field of multiple sclerosis. It's an old concept in other conditions like cancer or hormonology. But in MS, it's quite new. And I think it's very nice to discuss about it. And there was some, maybe we can start the discussion on that, on de-escalation and stopping treatment with aging, but in a more broader picture in MS patients.
Sure. Well, I mean, there actually is a question from Caroline which feeds into this directly. And she says there's so much work in diagnosis, new patients and new treatments, but there's many people who have had MS for many years, who are aging, who have comorbidities, and who may well have been diagnosed before DMTs ever came out. And it feels like we're being forgotten about.
Yeah.
And I could come to both of you to saying, do you think that is the case?
I completely agree. We do have a lot of missing issues in treating this disease. Mentioning what Romain was saying, we heard this morning in the late breaking news interesting data for many people that are being treated with drugs that we call anti-CD20, which are these drugs that many people are receiving every 6 months. And the Swedish who started doing this treatment many years ago, and as mentioned also by Romain, we see that in the long term, using these drugs, it is true that we don't see relapses, we don't see new lesions. They do lessen a bit progression, although not completely, but especially in aging population, they can start having higher risk of infection. So in the majority of people, it can be feasible to treat them instead of every 6 months, and the data that were shown this morning clearly confirm that you can treat them same efficacy, giving the drug instead of every 6 months, every 12 months. With this, the disease is still with a very good control in terms of inflammatory activity, but on the other side, with this we can decrease the degree of complications. Okay. Of course, as you mentioned, repair and the strategies for remyelination are still our biggest gap, I would say, together with effective treatments for progression. And if you want, we can start the discussion on these very much needed topics.
Sure. And there have been a number of questions on standardizing neuropsychological evaluations and on treating these symptoms. And I think this will come up in the next panel session as well. Romain, do you want to come in on that topic?
Yeah, I really appreciated the work of our colleague from Sweden. They are pioneer in that. It's using this new drug that is, we know, very efficient, but also to mitigate the risk associated to these very powerful drugs. And they are, doing real-life evaluation and clearly demonstrated that we are probably over-treated most of our patients. So we have to find out a way to decrease the risk associated, despite maintaining, of course, efficacy. And also, back to aging, we know that maybe we should not be as impactful as we are in young patients. And by the way, we have also a very nice study, maybe it's about the efficacy of this anti-CD20 drug in pediatric onset multiple sclerosis, because as you know, as Mar said, by contrast to aging patient, pediatric onset multiple sclerosis is clearly associated to a high level of disease activity, high level of lesion burden at MRI, and we were a bit frustrating to do not use these very active drugs. And there is a very recent data on the use of anti-CD20 drug in pediatric onset multiple sclerosis that demonstrated clearly a high impact. So now I think we have to treat this patient very actively at start. It's an important message, I guess.
Yep. So there's another question. It's a specific question, but actually several people have come into this. It's someone who said they've been diagnosed as having secondary progressive MS, but the last 2 scans have shown no change. Does that mean that that label is incorrect?
Well, I think we are now in the process of understanding that, in fact, this disease has 2 components. There's a more acute inflammation, which is responsible for relapses and for new lesions. And there is a more chronic inflammation, which is responsible for this small increase in disability. And these 2 phenomena are clearly present from the very beginning. So probably when what we are calling secondary progressive MS is only what happens at the end, but in fact this progression has started much earlier.
Yeah.
And this is what we are now recognizing clearly.
And although MRI is quite important, it only shows some aspects of the condition, and the fact that the MRI doesn't change doesn't mean there aren't changes occurring.
We are only able to see probably the acute inflammation.
Yes.
And
Yes.
this chronic inflammation, we are just starting to learn how
Yes.
to identify it with
Yeah.
MRI.
So, Romain, you mentioned de-escalation earlier, and Enrico's come in with a question to say about de-escalating. Is it true that DMDs worsen your ability to defend yourself against any kind of infection?
It's a good point. Fortunately, we are now moving to treatment that are more focused on a part of the immune system. At the start, 30 years ago, we were using drugs that were affecting all the immune system. It's not the case anymore. So we know we can anticipate what is the risk associated to these drugs. And it's more easy for us and for the patient to prevent the risk of infection that exists, of course. But we can prevent it quite easily with vaccination, with a follow-up of blood examination, and of course with clinical evaluation. So I would say now we are not using immunosuppressive drug, we are using targeted drug with a limited risk of infection.
Yeah, that's really, really, really helpful. And then Victoria comes in to say, we know CD20 agents are effective, but they have minimal impact on PIRA. Besides, what do we think will BTKs be better for PIRA?
That's right. So we know that with anti-CD20, we are very effective in taking out the acute inflammation, but we need something that targets more this chronic inflammation. And this is where BTK inhibitors seems to have a role. BTK inhibitors are an oral drug that can cross the blood-brain barrier and can target our brain better than monoclonal antibodies such as anti-CD20, who are not so able to cross the blood-brain barrier. So we believe that the BTK inhibitors can be the first strategy that really enters into the brain and is able to target this chronic inflammation that probably is responsible for this progressive that we now call PIRA.
Yeah, yeah, no, that's fair. Now, you've caused a certain amount of confusion, Romain, by talking about Sweden, and I think the drug that you're referring to there is rituximab.
Exactly.
Okay, so then, and they've several. There's been a bit of a discussion about it, but it is actually rituximab. So you're absolutely right. Yeah. But I think, unfortunately, our time has come to an end. Now, just no panic, because there's going to be another panel discussion in about 5 minutes, so you can take a little bit of a break, and then you'll move into the other room and carry on with some of the same issues, and re-ask your questions if you feel we haven't answered them or had time to deal with them. So thank you all very much for listening to us.
Thank you very much.
Thank you very much.